So today we'll discuss about the anatomy of rectum and the surgeries for rectal cancer. Okay, there is I find many people, they come to me and they say that they find it very difficult to understand the anatomy of the rectum when it comes about the different types of fascias and when we do the surgery, when to go for LA, when to go for APR. Okay, so first Dr. Sandeep Madan sir, I'll invite him to take this anatomy part, and basically he'll be focused on mostly on the anatomy which is going to be as a surgical anatomy, which will help you to understand that when we do surgery, what are the different layers comes and the different aspects about the rectal anatomy. And then we will go to the rectum part, rectal cancer part. There I'll discuss one or two questions and we'll see that what kind of surgeries we can do in the rectal cancer. Okay, so over to you, Dr. Sandeep Madan sir, for any kind of for the very brief description of the rectal anatomy, including something about the. Okay, so over to you, Sandeep Madan sir.
Thank you so much, Dr. Gaurav Patel sir, and a very good evening, everyone. How are you guys? Now let us start the discussion on the rectum anatomy, rectum and anal canal anatomy. Okay, so let me share the screen here. And
okay, so sir is sharing the screen. Just from all of you students, just I want to know that whether you understand, whether you know that okay, in the rectal cancer, when to go for LAR, when to go for APR, when to go for Hartmann's procedure. What are the new advancements in the treatment of rectal cancer? Okay, have you read about these things?
All right, dear students, let us start the session now. Okay, and here what we can see, this is, I have put one question. Okay, just to, you see, revise this part quickly. We'll start with the question. Okay, so this is the question. All of the following statements are true except, okay, choices are these. Rectum is completely enveloped by the peritoneum. Middle rectal artery does not supply anal canal. And fascia in front of the rectum is the denervated fascia, and the behind is the Walder's fascia. And the mesorectum contains the superior rectal vessels and the lymphatics. Yes. Now tell me in the chat box, what do you think will be the answer here? So this is a given question. You tell me, what do you think will be the answer here? Yes. So let us start the anatomy part. We will discuss the basic anatomy. After that, Gaurav sir will take over and he will describe the surgical aspect. Okay. So let us discuss the anatomy, then we'll come to the question again. In the meantime, you can try, right? So although the name rectum suggests that actually the rectum meaning is straight, okay? But even though the name is rectum, it is not a straight structure. It is having the curvature both in the lateral direction and the anterior posterior direction. So we can see we have this sacral curve here and the perineal curvature here, right? And it is not that the rectum is a straight, like directly opening into the anal canal and is like a straight tube. It's like curved tube, right? And here we can see we do have lateral curvatures as well, upper lateral curvature, lower lateral curvature, and in between we have middle lateral curvature, okay? Now, actually, as per the Gray's anatomy, it is given that it is variable in the absolute length, right? But it is, for the clinical practice, it is described around 15 centimeter from the external anal margin. This is what is given in Gray's anatomy. For clinical practice, we consider 15 centimeters roughly, they consider like that. Okay. Now you see, this is very important for us. This is a pure rectalis. This pure rectalis is actually helping in the maintenance of this angle. Okay, this is the support. It's a part of the pelvic diaphragm part, right? As we know, we have the levator ani muscle. Truly speaking, pelvic diaphragm is having two muscles, right? Levator ani plus coccygeus. But for clinical practice, usually we consider levator ani as an equivalent to a pelvic diaphragm. But this one of the muscle is pure rectalis. It helps in maintaining the curvature, right? This curvature is important here. So now let us see the peritoneum reflections. As you are aware, the rectum is present in the pelvic cavity, not in the abdomen, right? Abdomen, we have the organ system present, where we have the stomach onward, like all the parts are there. But this sigmoid colon will continue as rectum, right? But that rectum itself is a pelvic viscera, just like urinary bladder and the uterus. So these three heavy viscera, they need the support from below, right? In the form of pelvic diaphragm. But when this rectum is present in the pelvis part, the peritoneum which is coming from above, it can only cover the upper part of the rectum, particularly So far as peritoneal reflections are concerned, the peritoneum is divided into three parts: upper one-third, middle one-third, and lower one-third part. Upper one-third part is such that it is having the peritoneum in front and also in the sides. Middle one-third only in the front, and lower one-third not at all related. Okay, so that is the relation. Now, with respect to your rectum, the fascia are important. See, in the pelvic region, we have certain fascias, and these fascias, they get thickened on certain areas. Like in these parts, they are given certain names. For example, right now we are looking at the male anatomy, and we can see this is the rectal ampulla. Some part of the rectum here, it is like widened. It is defined as the ampulla. And in front, you see we have, just in front we have urinary bladder, ureter, ampulla of the vas deferens, seminal vesicle, right prostate. All these structures are present anteriorly, but they are separated from the rectum because of this fascia presence. And this fascia in male is well defined. And what is the name of this fascia? It's Denolvillier's fascia. And we have one fascia behind the rectum, which is actually connecting to the sacrum part here. This fascia is called as Waldeur's fascia. We appreciate this. So we have anterior and posterior well-defined fascia in case of male, but in case of female, we have a similar kind of fascia, rectovaginal fascia, but this fascia is ill-defined. It is not well-defined, okay? It is ill-defined there. Is that okay? Now, see this. When we look at the inside of the rectum, there we see the Houston valves are there. Houston valves, like we have actually 4 valves. But let me tell you, most of the books, they have defined the valves number as 4. Okay, a little bit different description is there in the grades. I will talk about that. But first, let me describe what is the usual anatomy described in the most of the books. See, we have 4 folds which are permanent folds, right? These are called as Houston folds, right? And here you can see the first valve. It can be on the right side, it can be on the left side, or it can be absent also. Okay. And the second valve usually on the left side, but again it is variable. Fourth fold usually on the left side, again it is variable. Now third fold is very important. It is most important and it is most constant. Now first of all, why it is most constant? See, why it is most important? See, the thing is, these folds, what is their role? They support the feces. That is their physiological role. And the third fold, it plays the role really well. So we don't want to compromise the fold. Any fold we don't want to compromise, but particularly third fold we are particular about. And this position is also constant. So that is how we try to maintain its to keep this fold intact. So what exactly is the position for the third fold? That you have to remember: the junction of anterior and right wall. The junction of anterior and right wall, that junction is important. So that is why we know the third fold is present in this direction. So if at all you have to pass the instrument and all, you will do in the left lateral position so that you don't want to injure this fold. Otherwise, holding the feces capacity will be gone. So that is not desired, right? Now we have understood these folds, but let me tell you what is given in the Gray's Anatomy. According to the Gray's Anatomy, it has given that total number they have considered 3, but they have also mentioned number can vary because they are not considering the first valve. So they are considering second, third, and fourth in the name upper, middle, and lower, like that. So they will write upper fold, middle fold, which is largest and most constant, and it lies above the rectal ampulla and projecting from anterior and right wall. So middle fold is basically what we learn as the third fold in the other books, okay? And the inferior fold is on the left and most variable. So basically, you should not get confused about the number of fold. Even the Gray's has said that it is the number can vary, and we must consider all the books of anatomy they are writing 4, okay? So better to go with that number only, right? Now let us talk about its blood supply. Basically, we can say the arterial supply, venous drainage, lymphatic drainage, right? And here, let me describe this arteries and all. Basically, superior rectal artery is a branch of inferior mesenteric artery, okay? And can you tell me this middle rectal artery is a branch of what? Middle rectal artery is a branch of internal iliac artery, and inferior rectal artery is a branch of internal pudendal artery. In case of whenever you are looking at the lymphatic drainage, I have always told my students that if you know the lymphatic drainage, then really good. But if you do not know, you can have a fair idea thinking about the vessels, because usually the lymphatics are drained along the vessels, right? So here we can see these vessels, and accordingly we can think of lymphatic drainage. So I will explain how. But just before that, let me show you the venous drainage here. So we have superior rectal vein, middle rectal vein, and inferior rectal vein. And these veins, basically, they will be making, these radicals of the veins will be making the venous plexuses, okay? So we have internal venous plexus and the external venous plexus. Okay, what is the importance and all? What is the surgical importance? That will be discussed later. Okay, but now let me come to this point of the lymphatic drainage, right? Let me explain this. Let me explain this. Just one moment. Now here we can see this. So if we talk about upper part, middle part, and the lower part, right? We have upper part, middle part, and lower part. Okay. In this part, what is the name of the artery? We have superior rectal artery. In this part, we have superior rectal artery, we have middle rectal artery, and we have lower part, we have inferior rectal artery, correct? Now, superior rectal artery is a branch of what? It's a branch of inferior mesenteric artery. So which lymph node will be carrying? Inferior mesenteric lymph node. Accordingly, it will be carrying inferior mesenteric lymph node. Okay. Then middle rectal artery is a branch of internal iliac, and accordingly we can think that internal iliac lymph node will be carrying the lymphatics from this part. Inferior rectal artery is a branch of internal pudendal, which is further a branch of internal iliac lymph node. So even in the lower part, it will be internal iliac lymph node. So basically we can correlate what is the blood supply. Accordingly, we can think of lymphatic drainage. I hope you understood this point. Yes, students, are you able to follow this much part? Yes. So this is how we can remember the, you can say this part of rectum, right? And the drainage part. And see, in the anal canal anatomy, let me explain. Anal canal anatomy is basically, we have 3.8 centimeter, which can also be written as 38 millimeter. And it is actually having three parts, right? Upper part, middle part, and the lower part. So let me describe this way. This way we can see this is, right? We have, this is upper part, middle part, and lower part. Upper, middle, and the lower part of the anal canal. Okay. This line is defined as what? This is pectinate line. This line is pectinate line. Okay. This is pectinate line. This line is dentate line. Pectinate line or dentate line, pectinate or dentate line, and the lower line is white line of Hilton. The lower line is white line of Hilton. White line of Hilton. Okay. And the part in between, this is called as pecten. The part in between is called as pecten. What are these folds? These folds are, these are anal columns, okay? These are anal columns of Morgagni. These are anal columns of Morgagni. Okay? And here we have like anal valves are there. These are the valves which I have marked here in the green color. And above this is called as anal sinuses. In these anal columns in the sinuses part, basically anal glands are present. But anatomically, what is more important for us is the pectinate line, because above the pectinate line and below the pectinate line, above the pectinate line, what is happening? Now it is okay? All right. Okay. So let me draw this line. We have this pectinate line here. Okay. Pectinate line above and below, we have different features. Above, we have it develops from the endoderm. Below, it develops from the ectoderm, the proctodium part. That is the proctodium part. Above, it is supplied by autonomic nervous system. Below, it is supplied by somatic nerves. Above the pectinate line, it is painful. Above the pectinate line, it is painless because of supplied by the ANS part, and below because it is supplied by somatic, so it is painful. Above, which artery is supplying? Superior rectal artery majorly. Okay, it is superior rectal artery. And here we have inferior rectal artery. Above we have portal vein. And below we have systemic vein. Okay. All right. Now here, so what about the lymphatics? Above it will be draining to, the lymphatics will be draining to internal iliac lymph node, and below superficial inguinal lymph node. Okay. And what about the epithelium here? What about the epithelium? We have stratified. Here we have, above we have simple columnar. Okay. Above we have simple columnar, which is the epithelium of GIT. And below we have stratified squamous non-keratinized, and further below we have stratified squamous keratinized. Further below we have stratified squamous keratinized. Okay. Now here this line is pectinate line, and this will be white line. So white line of Hilton is basically described as mucocutaneous junction. Okay, because we have true skin on one aspect. Okay. So here we are almost done with this part. Okay. So yeah. So if we talk now about this, and we have already seen this, right? Just let me show you this. We have already seen this part. Okay. And here what you can see, this is the comparison of upper and the lower part of the anal canal, but we have taken the notes, that is what, right? And here, all of the following statements are true except. Now, what do you think will be the answer? Rectum is completely enveloped by the peritoneum is the wrong choice, so that's why A will be the answer. B choice is true. Middle rectal artery, they are the short vessels, right? They are the short vessel. They supply in the rectum and they end in the rectum. They do not reach the anal canal. The fascia in front is the dental-villus fascia. Behind is the Werder's fascia. In case of male, this fascia, like dental-villus fascia, is present. It's like well-defined. In case of female, it is like ill-defined fascia. The mesorectum contains the superior rectal vessels and the lymphatics. That is true because these vessels and these lymphatics, they need the folds of peritoneum, right? So they will be, this fascia is there, that mesorectum, that will be used by the vessels and the lymphatics, right? So that is all. Now I will ask Dr. Gaurav to take over and he will be describing, right? Please unmute.
Hello? Is the voice clear?
Your voice is clear. Voice is clear. Please go ahead.
This is audio video clear? Is it clear? Okay. Sorry, my internet connection is somehow today. I'm not at home, so I don't know. Anytime it can, stop. So let's see. Let's start. Okay. So let's see the first question. The following statements regarding carcinoma rectum are true except. Okay, most patients with rectal cancer will require APR surgery. APR is abdominoperineal resection. Early morning spurious diarrhea is typical symptom. In locally advanced tumors, pre-op chemoradiotherapy surgery possible. And following an anterior resection, a defunctioning loop ileostomy is usually performed. Okay, so first let me tell you about, here only we'll see, about carcinoma rectum, okay, which is a very common, you can say in the colorectal cancer, rectum is the most common cancer. Okay, I'm not going into the risk factors, and can be dietary risk factors like animal fat consumption and red meat consumption. There are hereditary risk factors like APC, gene mutation leading to familial adenomatous polyposis, such NPC syndromes. Okay, there can be radiation can be a risk factor. So apart from the risk factor, let's see clinical features. Clinical feature in the rectum, when the malignancy occurs, it can lead to obstructive type of feature, or it can lead to like bleeding per rectum. Early morning spurious diarrhea. Early morning spurious diarrhea is like in the morning, patient wakes up early, maybe at 4 or 5 in the morning, and he feels as if he is going to defecate, but when he goes to the washroom, he just passes some amount of gas and just the liquid, that is mucus, not stool. So spurious means false diarrhea. Okay, so because the overnight collection of the mucus, the patient passes in the morning. Also, he feels there is a clinical feature where the patient feels there is a constant need to urge to defecate.
Recording in progress. Recording stopped.
Okay, sorry for this interruption. I guess this is from side. Okay, so now audio video is fine. Now is it okay? Okay, so treatment of rectal cancer in case of early cancer. Early cancer means when it is T1 or T2. T1 is when there is involvement of submucosa. T2 is when there is involvement of muscularis propria with N0, M0. In these cases, you can go straight away with surgery first. Okay, but in case of what has happened? In case of like T1, T2 with node positive or T3, T4 node positive, negative, in these cases, you need to first give chemoradiotherapy. Okay, so you need to give neoadjuvant chemoradiotherapy and then you need to go for surgery. So we're not going to discuss the whole management of rectal cancer. We are here to discuss the surgery part, that is along with the Sandeep Madan sir, because he has dealt with this anatomy very nicely, all the important points he has covered, and I'm sure that you have understood the basic anatomy. Now, when we talk about rectal cancer, see, suppose this is descending colon, this is sigmoid, this is rectum, and this is anal canal. Okay, this is anorectal ring, which the sir has discussed. Anorectal ring is very important for maintaining the continence mechanism. Okay, so whenever we do surgery, see, our proximal extent of the resection will always be at the junction of descending colon and sigmoid. This is the proximal extent. Okay, early cancer, the treatment is it is straight away, Shubham, surgery. Okay, in case of early cancer, you can go straight away with surgery, but in case of locally advanced cancers, you have to first give neoadjuvant chemotherapy and then go for surgery. Okay, so this is the proximal extent. Now let's see if the tumor is in upper third. Tumor in upper 1/3 of the, suppose here. So in these cases, we'll take approximately 5 centimeter distal margin, and this is the distal extent. Distal extent. And then after removing this, you will join the descending colon with the remaining part of the rectum and anal canal. Okay, so this is known as anterior resection. Anterior resection. Anterior resection. Because 5 centimeter distal margin you have to take. Okay, one more thing we'll see. Sir must have told you about that there is around the rectum there is something known as mesorectum. Okay, this is the mesorectum from where the blood supply, the vessels and the lymphatics are run. So when you do an anterior resection, because you are leaving a part of the rectum behind, so this is a part of the mesorectum is left behind. Okay, so this is different as compared to when we see the other type. Okay, so this is the treatment, anterior resection, if the tumor is in upper 1/3. Now let's see. Suppose descending on sigmoid rectum, tumor in middle or lower. So suppose here. Okay, and one very important thing is whenever we take this will be the proximal margin. This is proximal margin. Okay, audio, is it totally not audible, or there is like it is coming as broken voice or something like that? Now distal margin, when we take distal margin, we should take like between 1 to 2 centimeters. Okay, 1 is the minimum. You cannot take less than 1 centimeter. So if this 1 to 2 centimeter is not going into the anorectal ring, anorectal ring means the sphincters basically. Anorectal ring, sometimes the right sphincter. Okay, so if your lower end of the tumor is, okay, if lower end of the tumor is more than 1 centimeter from the sphincter, or anorectal ring, then so what you can do is you can take the distal margin here, preserving the anorectal ring. You will remove this thing, this whole thing, and you can do the anastomosis of the remaining descending colon with this anal canal. Descending colon, anal canal, this is, your ring is intact. Your ring is intact. Okay, so this surgery is known as LAR. LAR is low anterior resection. Low anterior resection. So one very important thing you will see that when we do a low anterior resection, to avoid the chances or to prevent the chances of recurrence in the future, we have to remove this whole mesorectum. Okay, the whole mesorectum needs to be removed. So posteriorly you go at the just anterior to the prevertebral fascia. Anteriorly you go up to the adenomulus fascia. So LAR surgery is a type of total mesorectal excision. Total mesorectal excision. Okay, total mesorectal excision. Now here only we'll see that if this lower end of the tumor, okay, suppose this descending colon, sigmoid rectum, if this tumor is involving or within 1 centimeter of anorectal ring or sphincters. Okay, if the tumor is involving the anorectal ring or within 1 centimeter, then the proximal margin will be this. This is the proximal margin. Distally, now if it is involving the sphincter, then you have to take out the whole rectum along with the anal canal. Along with the anal canal. So this surgery is known as APR, Abdominoperineal resection. Abdominoperineal resection. So when you do this APR, then you don't have anything down there, okay? You remove even the anal orifice. So you need to make the descending colon as a permanent stoma. Okay, there will be, like, suppose this is bladder, there is this urethra, that is fine. The anal opening will be closed with the suture. Okay, so this is following APR, you have to make a permanent descending colon stoma. Okay, so in APR also, when you do the surgery, you need to remove the whole mesorectum. Okay, in APR also, TME is done. Total mesorectal excision is done in APR also. Okay, so now you tell me first that now you have understood or not that what is anterior resection, what is low anterior resection, what is APR, what is the meaning of TME, total mesorectal excision. Okay, so see, whenever we do this surgery, whenever we do this rectal surgery, when we do the mobilization of the rectum, sir must have told you there are so many important nerve fibers are present there, especially in case of males. If there is injury to these nerve fibers, it can lead to severe consequences. Impotence is one of them. Okay, so that's why whenever we do the rectal mobilization, it takes time. Okay, it takes time. It can take maybe like 2 to 3 hours or maybe sometimes 4 hours. So in that case, now a very important question. If patient of rectal cancer comes in, suppose he comes with the features of obstruction or perforation or suppose severe bleeding. So obviously if the patient has come to the emergency with these problems, patient will not be hemodynamically stable. Okay, and if the patient is not hemodynamically stable and you take the patient for a surgery which is going to last for like more than 3 hours, 4 hours, then there are very high chances that there can be severe metabolic consequences can occur in the patient and you might lose the patient during surgery itself. So that's why in these cases what you do is suppose this is descending colon, sigmoid, rectum and anal canal. So suppose this was a cancer which was causing obstruction or perforation or something. So you will simply remove just this part, okay, which is causing the main problem. And then the proximal part you can bring out as a temporary stoma and the distal part you can simply close. Okay, suppose this is the remaining part of the rectum. This is the part of the sigmoid which you have taken out as the stoma. This is anal canal. So you have simply removed that part which was causing the main problem like obstruction or bleeding or perforation. And instead of doing any kind of anastomosis, you will bring it out as a stoma. So here when you do this surgery, you don't see any principle of like total mesorectal excision or the oncological principles. You will simply take out the thing which is causing the immediate problem. Okay, so this surgery is known as Hartmann's procedure or Hartmann surgery. Okay, this surgery is Hartmann's procedure of Hartmann surgery. When you cannot do a long duration surgery, you need to do, so you can say this is a kind of just a damage control which you are doing to the patient, and later on when the patient survives and that time you can do the staging again. And if the patient is fit enough for a big surgery, you can take up the patient and go for LAR or APR depending on the tumor status. Okay, so one more thing I'll tell you, that minimal invasive surgeries, or you can say local. Yes, later when you do the surgery, if you are doing LAR, you can go for anastomosis. But if you are doing APR, then obviously there is no anastomosis. Or local resection. There are two types of procedures. I'll show you these images. One is known as transanal minimal invasive surgery. Transanal minimal invasive surgery. Okay, and there is transanal excision of tumor. You can say transanal microscopic excision. Microscopic excision. Okay, so these tumors, the indication for these tumors, these surgeries, when the patient is either T1 or T2, with definitely patient should be N0. The size of the tumor should be less than 3 centimeter, and the circumference of the tumor should involve less than 30% of the rectal circumference, and it should be mobile. The tumor should be mobile. So if the patient is fulfilling these criteria, then we can go for this transanal excision of the tumor also. Okay, now I'll show you some of the images and then we'll go and see the questions. So sir must have covered about anatomy. I'll just show you. See, this is the rectum. This is the rectum. And see, this part, this is the mesorectum. Okay, anteriorly there is renal fascia, posteriorly this Walde's fascia. Okay, so when we do the surgery, we need to take out this whole mesorectum. But at the very same time, you have to be very, very careful, because if you go more deep, you can injure the presacral venous plexus, and the injury to the presacral venous plexus can sometimes be troublesome, and it is difficult to control that bleeding. Okay, so in another view I show you, so this is rectum and this is mesorectum. This whole thing, yellow color thing, this is mesorectum, which contains the lymphatics. So that is the principle of taking out the whole mesorectum, because if you leave the mesorectum, it might result in the recurrence. But you can see this is the line. This black line is where you need to take it out. If you go more posterior, you might injure the vessel. And on this side, laterally, there are these lateral stalk, very important neovascular bundles, and injury to these can lead to, I told you, potence. Okay, yes, you need to go between the dental fascia and the Walde's fascia. You need not have to take out the fascia as such, but yes, if you take out the fascia, it becomes like, it is easy to know that, okay, you have removed it completely. Okay, so you can take out the fascia also, but that's not a problem. But you should not go beyond that, because that can lead to injury. Okay, another view I'll show you. So correct dissection, the mesorectum, this dotted line is coming like this. Okay, and in dissection, when leave a part of the mesorectum behind, that is incorrect dissection. Okay, so you should not leave mesorectum behind, especially in case anterior dissection, 5 centimeters, then you take almost all lymphatics which are involved by the tumor, so that is not a problem. But in case of LAI and AIIMS, you have to take the whole mesorectum. Okay, this is the thing the dotted line shows. Okay, so this part you need to take. This is when you do a transanal take out tumor part, thickness, you need to take this out, and after that you can take the suture and close the defect. So those are the low, you put this inside, you go and dissect this tumor. Okay, this is the margin marked artery, and then we'll do the dissection thickness, and then you need to, this is AP, move this also slowly and very safely go move the internal sphincter, and this is how the surgery is done. And then you finish surgery, this close, and the patient will have. Okay.
Yeah, I think Gaurav sir's network is not working properly.
You remove the, this is the rectum as well as the anal canal. Okay, this is external sphincter, this is internal sphincter. Okay, so there is a modification of this APR which has come, because sometimes in case of conventional APR, find that at this part when there is wasting occurs of the specimen, so recurrence can occur. Will take this levator also. Okay, so when you take this levator, right? So when you take this levator, that is known as extra levator abdominoperineal. Okay, so this is extra levator abdominoperineal extensive surgery, and there are modifications, excision. So your excision goes between the internal and external. So this is a sphincter preserving type of APR. Preserving type of APR. Okay, so these are some of the new, say, the modifications or the new advancements in the surgery of the rectum. What is the, you just need to know that something known as extra levator abdominoperineal excision canine muscle also. And there is something known as intersphincter that where instead of removing both external and internal sphincter, you just remove the internal sphincter and external sphincter you can there, and then you can bring the descending colon there, and the patient might become continent and he can control his defecation. Okay, so these are the things in the rectal cancer surgery, in the rectal cancer treatment. I hope the images also, as well as the part which you have discussed, was of some use to the students. So just let me know. Okay, and over to you, Sandeep sir, because my net anytime it can go. So please wrap up this session. Thank you very much, all the students, and thank you very much, Sandeep sir. It was a very nice discussion, a very illustrative. This thing, the anatomy of the rectum you have described to the students. I'm sure that all the students must have been like they have benefited by your session, your talk. Okay, over to you, Dr. Sandeep sir.
Thank you so much, Gaurav sir, and it was really wonderful to see how beautifully you have explained like all the incisions and many new things I have learned today along with the students. I am really pretty sure that they must have enjoyed your session. Little bit here and there network issues were there, but I think it was all manageable, and you could wonderfully present the cases and this different type of incisions, different type of surgeries. I believe everything was fine. Dear students, so this was today's session where we have discussed rectal anatomy, anal canal anatomy, along with the applied aspect, the surgical aspect specifically.
Okay, just one minute, sir, one minute.
Yeah.
Just one thing. I did not give them the answer. Actually, the question which I had asked. Okay, so just last 1 minute. The following statement regarding carcinoma rectum are true except following the anterior resection, a defunctioning loop ileostomy is usually performed. Okay, that is true statement. And later on, after maybe 6 weeks, you can reverse that loop ileostomy. In locally advanced tumor, pre-op chemoradiotherapy makes possible. That is true. Early morning spurious diarrhea is typical. True. Most patients with rectal cancer will require APR. That is the incorrect statement. Okay, these days, because we have like the better instruments, better staplers, and also in many cases we can go for LAR, which were previously most of them were the APR. Okay, so the option number A is incorrect. One more question. Local excision of the carcinoma rectum is done in all except tumor in distal rectum, correct. Less than 3 centimeter, correct. Less than 30%, correct. T1, T2 cancer is correct, but it should be without lymph node involvement, not with. Yes, so that's why this option is incorrect. Option number D. Okay, so these were the two questions as per the rectal cancer was considered, and these two are the like exam questions, important questions. Okay, so over to you, Sandeep Madan sir. Okay, we'll wrap up this session. I hope the students have understood the concept, basic concept, and you are most welcome. If you have, if there is any doubt, anything, any controversy, you can tag us on the AIIMS Exclusive Club. Okay, we are more than happy to answer your queries and your suggestions. Okay, so thank you very much, and good night, Dr. Sandeep Madan sir. Okay, it was a wonderful session. Thank you very much.
Thank you so much, everyone. Good night.